Yeah, thank you so much, Dr. Marks, for the invitation to speak. It's an honor, especially, having done my training here in this department. It is a big honor to be able to come back and speak to you today. And since I have your attention, I know that the name change has been a little bit confusing and that my scheduling template is still under Lampy. So if you're trying to message me, look under Dominguez. Alyssa Lampy and Alyssa Dominguez are the same person, which I know has caused some confusion. So today we are going to be talking about the updated medical management of diabetes, focusing mostly on the 2024 ADA standards of care. And these cover a wide variety of things, including medical management and discussion of some management of comorbidity. So we'll be talking about several different things today. My one disclosure is I'm an advisor for a biotechnology company that's not related to the content of this talk. So today we'll be going through briefly epidemiology, diagnosis, treatment, some discussion of management of comorbidities, and some special situations, including preconception counseling and inpatient management as well. So in regard to current population data, about half of U.S. community dwelling adults with diabetes have achieved an A1C of less than 7% based on data that comes from 2015 to 2018. Which a goal A1C of less than 7% is our goal for many patients with diabetes. So we'll talk a little bit more about situations where our A1C goal might be different. Additionally, the goal blood pressure of less than 130/80 millimeters of mercury was achieved by less than half of adults with diabetes, which is the recommendation by the American Diabetes Association, and 70.4% achieved the blood pressure goal of less than 140/90, which is the recommendation by JNC8. So all that to say, we do have some room for improvement of helping our patients reach their target A1C and blood pressure goals in the United States. There are also some additional disparities. Here in Los Angeles, we, of course, have a very diverse population of patients that we treat. There are some populations that have been shown to be at risk for undertreatment, such as Mexican American individuals, non-Hispanic Black individuals, and underinsured individuals. It has also been shown that up to 25% of people with diabetes who are prescribed insulin do report cost-related insulin underuse. So, of course, as we're coming up with treatment plans for patients, we want to take into account their entire life situation, including medication affordability, which I will touch on a little bit later on. In regard to diagnosis and screening, the 2022 ADA guidelines changed the recommendation of having all patients be screened for diabetes starting at the age of 35 years. There are many other categories of patients in whom screening should be considered earlier. In patients who deal with overweight or obesity, with the BMI cutoffs depending on ethnicity, those who have a family history of diabetes, cardiovascular disease, hypertension, elevated cholesterol levels, PCOS, physical inactivity. Patients who have a prior diagnosis of gestational diabetes should have lifelong testing at least every 3 years. For everyone, even if they have a normal test, testing should be repeated at a minimum of 3-year intervals. And those who have HIV, exposure to high-risk medicines, and a history of pancreatitis also should be screened. So to summarize, everyone should be screened at least beginning at age 35, but there are several other factors that apply to probably many of the patients that we're seeing, especially here at CAC, where patients have very complex medical histories often, where we should be considering screening them sooner. The guidelines this year did increase the specificity of high-risk medications that should be considered when considering earlier testing, such as glucocorticoids, which for those of us who treat patients who have received transplants, we know that those raise the blood sugars considerably. Statins, medications, which definitely have been shown to increase fasting glucose and the prevalence of diabetes, thiazide diuretics, which increase glucose to a lesser extent, and then second-generation antipsychotics, which we know are often associated with weight gain, which can lead to insulin resistance and hyperglycemia, but have also been shown to have some glucose raising effects in and of themselves. The tests that are standardized to be used for the screening for diabetes are, of course, a hemoglobin A1C, which is probably what a lot of us are using, with a cutoff of 6.5% or greater, a fasting plasma glucose of 126 or greater, or a 2-hour glucose of greater than 200 after an oral glucose tolerance test. The recommendations do specify that the test that we use should be NGSP certified, which I confirmed with our lab that both the laboratory and point of care A1C tests are. Additionally, if an individual has a presentation with a glucose of greater than 200 and symptoms of hyperglycemia, that also makes the diagnosis of diabetes. In that situation, the test does not need to be repeated, but in these other cases of the A1C, fasting plasma glucose, or 2-hour post glucose tolerance test glucose, those should be repeated to confirm the diagnosis of diabetes. I'm not going to go into this kind of complicated workflow here, but this is something that was added this year to discuss testing for type 1 diabetes in patients who maybe have atypical presentations. So really here, I consider to be important is kind of think about who our clinical systems for and additional testing. If we're starting to get down here thinking about testing for MODY or things like that, it would definitely be appropriate to refer to us over in endocrinology at that point. So what I think is kind of the important thing for people who are especially like in primary care to think about when maybe we might want to suspect type 1 diabetes would be having an increased suspicion for patients who are at a younger age at diagnosis, so under 35, especially patients who have a lower BMI of less than 25, unintentional weight loss, and a plasma glucose of greater than 360 at presentation. Some of these are a little bit more atypical for type 2 diabetes, certainly. And if your suspicion is a little bit higher for type 1 diabetes, the antibody tests that I will often order are glutamic acid decarboxylase 65, zinc transporter 8, or anti-islet cell antibodies, and a C-peptide. In the setting of type 1 diabetes, we would expect that eventually the C-peptide would be low. It's not always low kind of early on in adult onset type 1 diabetes. But all that to say, the antibodies can sort of provide some helpful prognostic information in terms of if the patient is going to completely lose their beta cell function, though patients can have negative autoantibodies. And in that case, we're really just monitoring kind of their glucose over time to see if they're going to end up needing to require insulin. So moving on to treatment, of course, we know that the cornerstone of management of diabetes, especially type 2, is lifestyle interventions. In regard to nutrition, there is no one-size-fits-all diet recommendation. The general eating pattern recommendations include inclusion of non-starchy vegetables, whole fruits, legumes, whole grains, nuts, seeds, and low-fat dairy products. It's recommended to minimize meat, sugar-sweetened beverages, sweets, refined grains, and ultra-processed foods. Non-nutritive sweeteners have been a hot topic recently, especially with people using them to kind of flavor their water, like diet sodas, artificial sweeteners used in coffee, things like that. The American Diabetes Association recommends that they may be an acceptable alternative to nutritive sweeteners such as honey, sugar, and agave, since they, in those situations, are replacing sugar or other carbohydrate sources. They can reduce calorie and carbohydrate intake, as long as they're not replaced with other calorie or carbohydrate sources. And the reason I emphasize that is because there have been some studies that have shown that in people who drink non-nutritive sweetened beverages, they may sort of make up for those calories later on by taking in carbohydrates or sugar from other sources. And one of the thoughts behind that is our bodies take in those sweet signals, but then when that nutrition from the carbohydrates or sugars doesn't show up, there's an increased hunger signal. So when I'm talking to patients about this, usually I'll say, hey, it's okay to use there's some kind of controversial recommendations on this, but I would be cautious with this to to avoid kind of taking in more carbohydrates and sugar later on. And certainly water is not going to cause any of those issues. So water is definitely probably the best thing for anybody to be drinking. In regard to physical activity, the American Diabetes Association has this schema here with sort of these 5 S's of sleeping, stepping, strength training, that sort of encompass the healthy physical behaviors. So we'll focus a little bit more on the step and strength training portion of it. So in regard to sitting, it's recommended to limit sitting and break up prolonged sitting at least every 30 minutes with short, regular bouts of slow walking or simple resistance exercises. And there have been studies that have shown that even just standing up from sitting every 30 minutes can have positive impacts on those. In regard to sweating, it is recommended that for anyone with diabetes that they get at least 150 minutes a week of moderate intensity physical activity, or at least 75 minutes a week of vigorous intensity activity spread over at least 3 days a week with no more than 2 consecutive days of inactivity. Additionally, people should be supplementing with 2 to 3 resistance, flexibility, and balance sessions. And I really, when I'm talking to patients, do try to emphasize this, adding some resistance training if they can. A lot of people are already walking when they come to see me, but we know that building muscle and reducing fat really does also help to reduce that insulin resistance. So strength training is particularly important. And especially with some of these newer incretin-based medications like Ozempic, that maybe are associated with some muscle loss, I'm always encouraging patients to both do some cardio and resistance training. In regard to monitoring, patients should be monitored by either A1C or CGM metrics, which we'll talk about a little bit more, at least twice a year or more frequently if needed. There are some situations that can cause A1C inaccuracy. Anemias we come across fairly frequently. I know for me, I see a lot of patients who have received transplants, and a lot of them have anemias that may be associated with that. And the A1Cs are very often falsely low compared to maybe the finger stick or CGM blood sugar data that I'm seeing. G6PD deficiency, recent transfusions, certainly if we're kind of looking at red blood cells that are not actually from the patient, that might cause the A1C to go in a direction. Use of drugs that stimulate erythropoiesis, maybe we'll have some younger red blood cells, which might cause the A1C to be inaccurate. ESRD and pregnancy all might cause the A1C to be inaccurate. So often when I have concerns that the A1C is inaccurate, maybe I'll look at the finger stick blood glucose values, getting a fructosamine sometimes, or CGM can be very helpful in these situations. When we talk about A1C target, a lot of times we will think about an A1C target of 7% or less than 7%. Because of the known reduction in risk of complications like eye problems, kidney problems, and neuropathy with that A1C level. But certainly there are other factors that we should take into account when we are looking at an A1C target for a particular patient. We know if they're going to have significant side effects with very intensive insulin treatment or sulfonylurea treatment, we might want to avoid those things. We know that there's a legacy effect of having good early control of diabetes. So we want to get their A1C under control as early as possible. If someone is older in age and has a shorter life expectancy, having that glycemic control really tight is not going to have the same benefit as if someone is going to live for a long time, because just it'll be less time for those organs and blood vessels and nerves to be exposed to that high blood sugar. If they have other comorbidities or complications, those might limit our ability to provide really intensive treatment. And certainly preferences and resources are a big factor as well. I especially think of some of my patients who have type 1 diabetes, who maybe don't have access to be giving themselves insulin all that often or can't check their blood sugar that frequently. It's really hard to get a tightly controlled A1C without them being at significant risk for hypoglycemia. In regard to diabetes technology, there have been a couple of new devices that have come out over the past couple of years that have been very exciting. The Dexcom G7 is one that I am using a lot for patients nowadays. It's much smaller than the Dexcom G6 was. It's one piece, unlike the Dexcom G6. It has a fairly easy applicator to use and is compatible with smartphones and is becoming a lot more compatible with insulin pumps. The Freestyle Libre 3, as we have pictured here, is obviously the third generation in the Freestyle Libre family, much smaller than the older ones. And both of these are the continuous, they give the continuous blood glucose data. The patient doesn't have to, swipe their reader or phone over it to get that data. I wanted to include the InPen. This is not one that I use for a lot of patients, but it is really beneficial for the people who are good fits for it. It's a smart pen that pairs with an app on the smartphone that's through Medtronic, and the app allows us to program in specific insulin doses for specific times, and the app also tracks when the dose of insulin was given and how much was given. So I think for me as a provider, that allows me to get some data when I see the patient of like, okay, this is their actual behaviors when they're giving insulin. This is also compatible with the Dexcom. So you can kind of see, I know here it's pretty small. We can see their CGM tracing also on the InPen report. So that can be really helpful in determining sort of, especially if somebody, or obviously this person would be on insulin, how their blood sugar is responding to specific insulin doses. And then finally, this device here is one that I honestly hadn't used a lot up until probably this past year, just because frankly, the company hadn't been advertising that much. But this is the Eversense continuous glucose monitor. This device gets implanted under the skin and is changed every 6 months. The patient wears this transmitter over it, and then the blood glucose data gets transmitted either to a smartphone or the reader. The nice thing about this is that this transmitter doesn't use an adhesive, it uses silicone. So for me, if some of my patients have issues with the adhesive with continuous glucose monitors, or sometimes they'll fall off, and then with the Dexcom or the Freestyle Libre, if it comes out, it's done. You can't put it back in. But with this one, you can just put it right back on. So it's not something that's necessarily for everybody. I would say most patients prefer probably the Dexcom G7 or the Freestyle Libre 3. But for those patients who maybe have like an allergy to adhesive, or have children or something who are peeling off their CGMs, like this for particular patients, it is a good alternative. So when we have patients come into the clinic and we're looking at their blood glucose reports that we get from this, there's different components of the report that we like to look at. Of course, we want to make sure that we're looking at the right patient and the right date range. We want to see kind of how often they're wearing their CGM. If they're only wearing it, if they only have it active like 10% of the time, like maybe they either just put it on or they don't have their reader near them, or if they don't have if we're not actually getting that much data, it's not as helpful. From this, we are able to look at the sort of time in the different ranges here. So there are different targets for percentage of time that a patient is in a given range of glucose. So the one that I usually like to start with is our time in this green bar target range, which is our percentage of time that the blood glucose is between 70 and 180. Our goal is to keep this percentage of time above 70%. Additionally, we want to keep this percentage of time in the high range on the low end, like less than 25%. And also, very importantly, we want to keep this percentage of time low at less than 4%, and very low, meaning a blood glucose of less than 54, at less than 1%. Obviously, that's a very low blood sugar. So I have found when I have patients coming into clinic with me, I will often review this particular kind of image with them. I think it's a really helpful visual tool of kind of, we want to kind of get this green bar up, definitely get these red bars down, and reduce the time spent in the high range as well. Some additional helpful information that we can get from a continuous glucose monitor is the glucose management indicator, or GMI, which uses their average glucose and calculates an A1C equivalent based on the most recent 2 weeks of data. I have found that to be very helpful when patients are used to kind of coming into the office and talking about a hemoglobin A1C. It gives us an equivalent to kind of talk about, and we use this on the most recent 2 weeks of data rather than an A1C is based on the most recent 90 days of data. So if, let's say, for example, we're like up titrating a GLP-1 receptor agonist or something where we're doing something a little bit more quickly, we're able to get a sort of A1C equivalent of what that result looks like without having to wait the 3 months to get an A1C. For patients who are using insulin or sulfonylureas, it's really important to screen them for hypoglycemia at the time of visits because, of course, that can be very dangerous on a short-term basis. It's important to at least consider and probably prescribe some form of glucagon for patients taking insulin or who are at high risk for hypoglycemia, like patients taking sulfonylureas. The forms that I prefer to use are either Baqsimi, which comes in an inhaled form. I think for a lot of patients that feels very accessible. They feel comfortable talking to their, roommates, family members, say like, hey, if you see me passed out, please check my blood sugar and give this to me. Definitely much easier than the sort of older red boxes where you have to like mix up the solution and the solid part. Another very good option is this Gvoke HypoPen, where all they need to do is pull off the red cap and then press it down into like their thigh. So thankfully, we have much easier glucagon administration solutions than we used to with those, red boxes. So patients who are on insulin should have this prescribed. So moving on to more of a focus on medical treatment. There are some kind of newer treatment priorities now that we have some of these newer medications like the GLP-1 receptor agonists, the SGLT2 inhibitors that have this really robust cardiovascular and kidney outcome data. So for people who have atherosclerotic cardiovascular disease or have high risk for it, patients who have heart failure or CKD, the treatment plan should include agents that reduce cardiovascular risk and kidney disease risk independent of A1C and metformin use. An update in the guidelines for this year is really also an increased focus on not just glycemic control, but also weight goals. We have these newer medications are, semaglutides, tirzepatides, dulaglutides that have really robust weight management data. So we're also prioritizing those outcomes for patients as well. This slide is a little bit busy. This is kind of the whole of the treatment algorithm for the management of type 2 diabetes. And we, as I said, we kind of focus on some different things, like focus on treatment of comorbidities, weight management, and then of course, glycemic control. So we'll focus on these a little bit more individually. So in regard to management of patients who have atherosclerotic cardiovascular disease, are patients who have stroke, MI, or even those who are high risk, who are like greater than 55, who might have some conditions like obesity, high blood pressure, smoking. One of the first two medications that should be started for them should either be a GLP-1 receptor agonist with proven cardiovascular disease benefit. So that's going to be our semaglutide, liraglutide, or dulaglutide, or an SGLT2 inhibitor with proven cardiovascular disease benefit. That's going to be our empagliflozin, dapagliflozin, or canagliflozin. And if the A1C is still above target, the medicine in the other class should be added. So for example, if we started with empagliflozin, maybe we'll add on like a semaglutide or liraglutide after that. Additionally, the guidelines here do also recommend consideration of thiazolidinediones. I don't use as much of those in my practice just because of the sort of weight gain, fluid retention, osteoporosis concerns, but those have been shown to potentially have some cardiovascular benefit as well. In patients who have heart failure, SGLT2 inhibitors should be really the first line. They've been shown to have benefit for keeping people out of the hospital, both who have diabetes and who don't have diabetes. So that should really be the go-to for those who have heart failure, at least to start out. And then for those who have CKD, SGLT2 inhibitors should really kind of be our initial go-to. If an SGLT2 inhibitor is contraindicated, not tolerated, or if the A1C is still above goal, we should be considering adding on a GLP-1 receptor agonist at that point, or starting one if they can't be on a GLP-1 receptor agonist. Just as a side note, a lot of the reason that the SGLT2 inhibitors are kind of the top recommendation at this point, the FLOW trial, which was a trial of semaglutide in CKD, did show benefit in patients who had CKD in terms of reducing the risk for like major cardiovascular events or progression of kidney disease. So I'll be interested to see in the guidelines for next year if that changes, if SGLT2 inhibitors are still going to be kind of the #1 recommendation, or if GLP-1s will also be along with the SGLT2 inhibitors, kind of like here in the atherosclerotic vascular disease. This is another kind of brief sidebar, but this is a medication called bixagliflozin, marketed under Brinzavi. When I have found this helpful tool in my patients who should be on SGLT2 inhibitor therapy, but have really high copays for our like Jardiance, Farxiga, things like that. Like some of my patients have come to me and said like, hey, I'm having to pay like $200, $300 a month for some of these medications with my current insurance. So we don't have quite the same cardiovascular outcome trial data for this medication, for the Brinzavi. There's some shorter term data that's pretty good, but it's only if it's prescribed through Mark Cuban Cost Plus Drug Company, which is the only place that it is currently available, it's only $48 a month. So I bring that up for patients who are in the category of they should be on an SGLT2 inhibitor, but maybe even with their insurance coverage, they can't afford one of the typical ones like Jardiance or Farxiga. I will often send people this medication because it's something that we can get for them that's a little bit more affordable. So moving on specifically to talk a little bit more about weight loss, these medications have been very frequently discussed in the news recently. I know are semaglutide or Ozempic or tirzepatide or Mounjaro are sort of the best in terms of weight loss, followed by dulaglutide or Trulicity or liraglutide or Victoza, followed by some of the other classes of GLP-1 receptor agonists and SGLT2 inhibitors, followed by DPP-4 inhibitors and metformin. So with the guidelines from 2024, we're really focusing more on not only just helping people achieve their glycemic targets, but also their weight management goals. And for those of us who've used these medications, we know that for a lot of people, they really do lose a lot of weight on these medications and do feel better. In regard to insulin, we should be talking with our patients about how type 2 diabetes is progressive. And certainly insulin is not meant to be like a stick or a threat as a sign of personal failure or punishment. If we're seeing somebody early on for diabetes, it's common practice to initiate insulin therapy for people who present with a blood glucose of greater than 300 or an A1C of less than 10%, or certainly if the patient has evidence of symptoms of hyperglycemia like polyuria or polydipsia, or evidence of catabolism like unexplained weight loss. If somebody is not kind of, for me, presenting with like weight loss, polyuria, polydipsia, I usually will add on insulin if a patient is on kind of the maximum tolerated doses of like metformin, either semaglutide or tirzepatide or dulaglutide, and an SGLT2 inhibitor with their A1C still above goal. Really, I try to maximize those medications that have a weight benefit where they're not going to be predisposing them to weight gain, whereas insulin we know does predispose somewhat to weight gain and has a higher risk of hypoglycemia. I prefer insulin over sulfonylureas due to glycemia with sulfonylureas and pioglitazone due to the fracture risk and fluid retention. I think other people may have different practices on that, but that's just my personal practice. Discussing a little bit more about weight management also, the recommendation on metabolic surgery is that it should be considered in all people who have diabetes with a body mass index of greater than 30 or a body mass index of greater than 27.5 in Asian Americans. And what I talk to patients about with this is I know that historically bariatric surgery has been thought to be very risky, it has a lot of side effects, but we do see here that people who have metabolic surgery do have a mortality benefit. So it really has, although there are certainly some things to consider like increased risk for malabsorption, osteoporosis. I do have some patients in my practice who develop post-bariatric surgery hypoglycemia. Really for diabetes, there are some really good benefits for bariatric surgery. So I do, especially if my patients are kind of have reached the maximum doses of their like incretin-based medications, we do have a conversation about that. So before we move on to comorbidities, I wanted to briefly summarize just the treatment of hyperglycemia. Nutrition and physical activity are really the cornerstones of management. Metformin may not be first line for everyone, especially those who have like ASCVD, CKD. We want to be using our GLP-1 receptor agonists, dual agonists like tirzepatide, SGLT2 inhibitors for heart and kidney disease. We know that the GLP-1 receptor agonists and tirzepatide have really good weight loss benefits for many of our patients, and we should consider starting insulin earlier for patients who have severe hyperglycemia in a catabolic state, losing weight, or when other medications inadequately control glucose. So shifting gears a little bit to the management of comorbidities. In regard to statin therapy, people who have diabetes who are ages 40 to 75 without ASCVD should be on a moderate intensity statin. Those who have diabetes who are at age 40 to 75 who are at a high cardiovascular risk should be on a high intensity statin to reduce their LDL by at least 50%, targeting an LDL of less than 70. For those who have known ASCVD, their goal LDL reduction should also be at least 50% with the target LDL of less than 55. If at age 75, they're already on a statin, we can continue it. If they're greater than 75 and they're not already on a statin, it's sort of a risk-benefit discussion, sort of depending on the age, comorbidities of the patient, and sort of what their preferences are. A study that came out last year, it was on the use of bempedoic acid and cardiovascular outcomes in statin intolerant patients, leading to this new recommendation of, for those intolerant to statins, using bempedoic acid. And what this study looked at was the use of bempedoic acid in patients who sort of should be on statins but are not. So we're seeing here that there are benefits for statin use in a variety of different areas, including like MI and some other cardiovascular outcomes. So we see here that there is benefit for using these in patients who are intolerant to statin therapy. Another option for medication use are PCSK9 inhibitors. PCSK9 is a protein that binds to the LDL receptor on the surface of hepatocytes and leads to the degradation of the LDL receptor. So if we block PCSK9, what we do is we increase LDL receptors. So we're taking in that LDL and we're lowering LDL cholesterol. So for people with diabetes who are aged 40 to 75 years at higher cardiovascular risk, especially those with multiple ASCVD risk factors and an LDL cholesterol of greater than 70, it would be reasonable to consider adding ezetimibe or a PCSK9 inhibitor to maximum tolerated statin therapy. And for people who have known ASCVD, it's recommended to add ezetimibe or a PCSK9 inhibitor if they're not achieving their goal LDL on maximum tolerated statin therapy. A new recommendation that came out this year was screening for asymptomatic heart failure. Heart failure does have a prevalence of 22% among people with diabetes. Identification, risk stratification, and early treatment of risk factors in the asymptomatic stage can reduce risk for progression to symptomatic heart failure. This recommendation cited the Stop Heart Failure study, which came out in 2013. This was a randomized control trial with about 1,400 participants with cardiovascular risk factors who were randomized to either usual primary care screening or screening with BNP testing. Those who had a BNP of greater than 50 or higher received an echo, followed by collaborative care between PCPs and cardiovascular specialist services. It was found that participants in the intervention group received more renin-angiotensin system blockade therapy. Though of note, one thing I did want to mention with this is only 18% of participants in this trial did have diabetes. So the application of this to people who have diabetes may be somewhat limited. And we see here that in the intervention group, they had a lower proportion of cardiovascular events. So that sort of led to this recommendation of checking a BNP for people who have diabetes. So the recommendation is to consider screening adults with diabetes by measuring a BNP to facilitate the prevention of heart failure. The biomarker threshold for abnormal values is a BNP of greater than 50 or an NT-proBNP of greater than 125, with abnormal values should be followed up with an echo. Another screening recommendation that was included in this year's guidelines was screening for PAD. This was based on the VIVA trial, which included about 50,000 participants, specifically men aged 60 to 65, to 74, living in central Denmark, who were randomized to either combined vascular screening for AAA, PAD, and hypertension, or no screening. The vascular screening was associated with an increased pharmacological therapy like antiplatelet, lipid lowering, and antihypertensive therapy, reduced in-hospital time for PAD and CAD, and reduced mortality. I thought this graph was interesting. Initially, I was like, I can't even see the difference between the two lines until I was squinting a little bit. So they did include this. There's not a huge survival benefit from doing this, but it is statistically significant. So the recommendation here is that in asymptomatic individuals with diabetes who are age greater than 50, with microvascular disease in any location or foot complications or any end organ damage from diabetes, screening for PAD with ankle brachial index testing is recommended to guide treatment for cardiovascular disease prevention and limb preservation. So in the study, we're not seeing a huge benefit, but this is one of the newer recommendations for PAD screening. Wanted to briefly talk also about finerenone. This medication was FDA approved in July of 2021. It is a selective non-steroidal mineralocorticoid receptor antagonist. The reason that this was added to the guidelines is due to its reduction in the primary composite outcomes of reduction in cardiovascular events compared to patients who received placebo. We can see here that a lot of the reduction in outcomes here is really driven by hospitalization for heart failure, not so much kind of by these other outcomes. So side effects of this medication include hyperkalemia, hypotension, and hyponatremia. It's contraindicated in patients who have adrenal insufficiency, who are not included with in the trials. It does have some drug interactions with CYP3A4 inhibitors like chlorthromycin and itraconazole. It can be kind of expensive, and insurance coverage is limited, though there is some copay assistance that is available. The recommendation is for considering use in patients who have diabetes and CKD, especially if they have albuminuria, because those are the patients who are going to get the most benefit. I have not used a ton of this in my practice yet. I know our nephrology colleagues are using this a little bit more, but I think it should be especially considered in patients who have like CKD and heart failure. Retinopathy is something, of course, we should be screening all of our patients for in at least every 1 to 2 years. It is the most frequent cause of cases of new blindness in people aged 20 to 74 in developed countries. All patients who have diabetes should be screened at least once every 1 to 2 years. We can reduce the risk of development and progression of retinopathy by optimizing glucose, lipid, blood pressure control, and it can worsen in pregnancy. A new recommendation this year was in regard to foot care, where an interprofessional approach is recommended, facilitated by a podiatrist in conjunction with other appropriate team members for those who have foot ulcers and high-risk feet, described as those on dialysis, those with Charcot foot, those with a history of prior ulcers or amputation, and those with PAD. We have a very strong podiatry program here at Keck, so I do send a lot of my patients over there and they get really excellent care there. So just a plug for our podiatry program, especially based on these new recommendations. For older adults, CGM can be really helpful, especially for those who are on insulin. What I really like for older adults is the fact that the continuous glucose monitors can have alarms, especially if the blood sugar is dropping really low. And for some of these, if they're using their like smartphone to check their blood sugars, they can also share that data with some of their family members through like, especially like the Dexcom Share app. So family members can keep an eye on also on their blood sugars. So I think that can be really helpful. Additionally, like we talked about a little bit earlier, glycemic targets are individualized. So these are some sort of general guidelines for that. For those who are healthy with the long life expectancy, we're probably going to use targets that are very similar to some of our younger patients, A1C of less than 7 to 7.5%, fasting or preprandial glucose is 80 to 130, bedtime glucose is 80 to 180, blood pressure goal of less than 130 over 80, with statin use unless it's contraindicated or not tolerated. Kind of our middle range is those with a variable life expectancy. Maybe they've got some other comorbidities, they've got some cognitive impairment. Maybe we'll target a little bit of a higher A1C of less than 8% with a little bit higher fasting blood glucose targets. And then, of course, if they have a lot of comorbidities, like some of our patients who have like metastatic cancer, limited life expectancy, really, I'm kind of more focused on avoiding like symptomatic hyperglycemia, keeping their blood sugars less than 200, and maybe not using so much statin therapy unless there's a compelling reason. I did want to briefly touch conception. Of us are seeing patients who could become pregnant. Those who have pre-existing giving interprofessional care for preconception, including endocrinology, MFM, a dietitian, nutritionist, and a diabetes care and education specialist when those are available. There are a lot of medications that we're using now for diabetes should not be used during pregnancy. One important one, since we're using a lot of these once weekly GLP-1 receptor agonists or dual agonists, is those are advised to be stopped at least 2 months prior to conception. So when I'm seeing a patient for the first time who could become pregnant, I do ask them about their pregnancy plans to discuss if maybe we need to have a timeline on when we're going to stop their incretin-based therapy. And one important thing that I tell patients for tirzepatide especially is that patients should use a backup form of contraception if they're on birth control pills at the time of initiation or dose escalation of tirzepatide, because there is some data that tirzepatide may interfere with oral contraceptive absorption. Additionally, SGLT2 inhibitors should not be used during pregnancy. So all that to say, if somebody is on metformin or insulin at the time that they get pregnant, that is okay. There hasn't been shown to be risk of fetal anomalies with those. And we discussed that we target an A1C of less than 6.5% prior to conception. We know that having that exposure to high blood glucose values early in pregnancy does increase the risk of fetal anomalies. So we want to make sure that before conception that we have their A1C below 6.5% and that they're not taking any medications that could be harmful to the baby. In regard to inpatient management, treatment should be initiated or intensified for glucose persistently above 180. The target glucose is still 140 to 180 for critically ill patients, as discussed in the NICE sugar trial, 100 to 180 for non-critically ill patients. For some critically ill patients, a target of 110 to 140 can be considered if it can be achieved without significant hypoglycemia. We definitely don't want those patients getting too hypoglycemic. There is some sort of new data on the use of CGM in the hospital where we're letting people keep them on, but we're using point of care glucoses for insulin dosing decisions and hypoglycemia management. We do like to keep, especially in endocrinology, our patients on their insulin pumps, especially if they have automated insulin delivery, if that is appropriate. We do have a power plan at Keck that allows patients to remain on their insulin pump if that's appropriate, if they're awake, if they're able to make treatment decisions regarding their insulin pump. For these patients, most of them having type 1 diabetes, we've put a lot of effort and thought into their carb ratios and corrections. So if the patient is able to continue to use that in the hospital, a lot of times that makes things a little bit easier than the sort of less targeted sliding scales or insulin dosing patterns that we have available in the hospital. For patients who have type 2 diabetes who are hospitalized with heart failure, there is a recommendation that use of an SGLT2 inhibitor be initiated or continued during hospitalization and upon discharge if there are no contraindications and after recovery from the acute illness. I had sort of been a little bit hesitant about this just because of the risk of euglycemic DKA and UTIs. So I looked a little bit more into the clinical trials that they used to generate these recommendations, which had pretty liberal exclusion criteria, kind of the medication could be held or not initiated at the discretion of the investigator, and they didn't really comment on DKA outcomes. So all that to say, like there are patients who have like heart failure where this would be appropriate, but I would be very cautious in making sure that the patient is eating okay, is not sick, to avoid precipitating euglycemic DKA before starting this in a patient who is in the hospital. The perioperative care is sort of a hot topic recently, as the ASA task force, I think this was last year now, recommended that patients hold their daily dose of the GLP-1 receptor agonist on the day of the procedure and their weekly dose 7 days before the procedure, just given some of these case reports that have come out that have shown food still left in the stomach, even if the patients had followed the appropriate instructions of fasting before the procedure. SGLT2 inhibitors should be held 3 days to 1 week prior to surgery. The FDA label says 3 days. One of our fellows presented some cases where the SGLT2 inhibitor is actually sort of hanging around still as long as 7 days after stopping it. So I actually lean more to like 1 week prior to surgery in having our patients hold those. There's an A1C target of less than 8% prior to surgery, and it's recommended to hold metformin on the day of surgery. It's also recommended to hold other glucose lowering agents the morning of surgery or the procedure and give 1/2 of the NPH dose or 75 to 80% of the long-acting analog insulin, or adjust the insulin pump basal rates based on the type of diabetes and clinical judgment. So I know we're kind of getting close to the end of our time. Okay, perfect. So all adults should be screened for diabetes in terms of take-home points, and then we'll have our question. All adults should be screened for diabetes starting at age 35. They should be screened before age 35 if there's other risk factors. They should be screened at least once every 3 years, but for a lot of people more frequently, depending on what else is going on. The goals of treatment may change with age or comorbidities. Patients should be treated for targeted comorbidities such as ASCVD, heart failure, and CKD, regardless of their A1C, with GLP-1 receptor agonists and SGLT2 inhibitors. We should make sure that our patients who are at risk for hypoglycemia have glucagon, make sure that our pregnants who could become pregnant are at A1C goal and not on teratogenic medications. And our goal in patient blood glucoses are 100 to 180 or 140 to 180, depending on their illness severity. And then I know we have our question here at the end, which I will read. A 64-year-old man with a history of type 2 diabetes, CAD, and heart failure presents for initial consultation. He is currently taking metformin, 1,000 milligrams twice a day, which he has been on for the past 6 months. He has seen nutrition and is trying to walk 30 minutes daily. His most recent A1C is 8%, GFR is 65. He does not have a history of gastroparesis, urinary tract infections, or osteoporosis. So our question here is, what is the next best step in medication management? And I can give people a few minutes to respond, however that is, like in the chat or otherwise.
All right, I think I have an answer. Dr. Dominguez, do you want someone in the audience to answer, or do you want to walk us through it? Your call.
Sure, like
Anyone else in the audience wants to chime in?
Yeah, if you whoever wants to answer, it's fine.
Yeah, I think the CAD and heart failure are kind of the key here to the answer. You and I were talking earlier, if maybe if it were just CAD, we would go the semaglutide route, but with the heart failure, I think empagliflozin is the one that we prefer.
Yes, that's right. So really the difference on the sort of point on this is just that that heart failure is like where we'd want to use the empagliflozin sort of over the semaglutide. Certainly, like we might want to add on the semaglutide later, but if we could only pick one, I would pick the empagliflozin.
Great, thank you. That was so comprehensive. Excellent. Really appreciated it. We have a question in the chat from Dr. Turner. Great talk. Love the tip about the Mark Cuban website. Question about GLT2 and older women with a history of frequent UTIs. Barbara, do you want to unmute and chat about your question further, or just have Dr. Dominguez comment?
No, I think you did a nice job of summarizing my question. Although I do have a question about the Mark Cuban. I noticed they have a way that you can have your doctor sign into the pharmacy. Do you have any tips about how we put that in our e-prescribing, or how you did it when you sent the drug to that pharmacy?
Yeah, so what I do just very specifically is, when you're typing in the patient pharmacy into that box that we do, you have to click mail order, and you can prescribe directly to the Mark Cuban Cost Plus pharmacy.
Okay.
So that's how I've been doing it. And then I believe I've had at least one patient who has been able to get it that way. So that does seem to have worked.
And then about the I mean, I don't know about the side effects of urinary tract infections, but it seems a problem, maybe.
Yeah, I agreed. That is something that I kind of bump into a lot. And I think different people have different practices on this. For me, if somebody is coming to me and saying, hey, I am already having a lot of UTIs, usually I won't use an SGLT2 inhibitor. Usually, like, I'll just say, okay, it would have been nice to use this. We'll probably use just like a GLP-1 receptor agonist instead. I have a couple of patients who, like, even despite recurrent like candidal and like UTIs, they're like, I really want to stay on this. So sometimes we will treat through it, but I would say that's the minority.
I think I have had arguably fewer problems with the infectious issue, but more the incontinence issue that I've found problematic with people too, just with the polyuria. I think Matt Young, as always, has come through with IT and shown us a screenshot of the example that Alyssa was just mentioning. And then I think Peter has his hand raised. Peter, would you like to ask a question?
Yeah. First of all, thanks so much for this talk. I haven't practiced primary care for 10 years, and so it's great to see how much diabetes care has really evolved. I'm really interested in this continuous glucose monitoring. And do you ever recommend it to, let's say, a pre-diabetic that just wants to have a behavioral intervention and know how their diet is affecting their blood sugars?
So I would say I have some patients who like have been able to get them, like some of my patients with like PCOS, for example, and they have used them and said that, oh yeah, this is actually really helpful. This helps me see how my blood sugar responds to certain foods. So I don't think I would necessarily recommend against it. One caveat I will often give to people is they can read falsely low at the lower blood glucose ranges. So one thing that can sometimes happen, people are like, oh my gosh, I'm having hypoglycemia. And I'm like, you're probably not. So that's one sort of caveat. I would say the biggest barrier to getting them for people who have prediabetes is the insurance coverage. Like even for some people who have type 2, it's not covered because they're like not on insulin or don't have a risk for hypoglycemia. Dexcom actually just announced that they have like an over-the-counter version that's going to be available, I think, sometime this year. I'm not sure what the cost of that is going to be, but I think that might increase availability for people who want it, like maybe who have prediabetes or their insurance wouldn't otherwise cover it. We may have some new access to that sometime soon.
That's awesome. Thank you.
Over-the-counter option sounds very intriguing. I think that may change the landscape a little bit. It'll be exciting to see. And Matt McFarland has a hand raised. Please feel free to chime in. Oh, Matt, I'm sorry. I don't think I can't hear you. If you're having audio trouble, feel free if you want to type something into the chat.
Sorry, I unmuted myself. Can you hear me now?
Yeah.
Okay. I was saying thanks, Alyssa, for always thoughtfully responding to my orchid messages without questions. But I was wondering, what are your recommendations for restarting the GLPs after procedures? Because I generally thought it was you start them once people are having normal bowel movements and eating reliably, but I've seen some providers recommend waiting a full month to restart. So I was wondering, do you have any thoughts or recommendations for that?
Oh, interesting. I guess, and just to clarify, like, I've not seen or heard of that recommendation of like waiting a month. Like, is there, I guess, is the rationale maybe behind that, like if they had like an abdominal surgery, kind of like waiting for the intestines to kind of wake back up, or do you know?
It was an orthopedic procedure, but I'd seen in the note for the person who generally manages the semaglutide had recommended waiting a full month to restart. And I was trying to find data for that. I just couldn't find anything. So I didn't know what your normal practice is.
Yeah, I think my head is kind of where yours is, where I'm kind of trying to think through like why that would be necessary. I can't think of any particular reason. I think what you were saying seems completely appropriate. If the person is eating, voiding normally, there's definitely nothing magic about waiting a month. So I would probably be wanting to restart it as soon as they're eating and voiding okay.
Thank you.
Great. Great. That was perfect timing. We're right at 1 o'clock, unless anyone has any other questions. Thanks so much. That was fantastic. Have a good afternoon, everybody.
Thank you.
Thank you.
Brandon, if